My name is Maja Mockenhaupt, and I'm a dermatologist. I'm working in Germany at the University Hospital in the city of Freiburg. I have been working on severe cutaneous adverse reactions for the past 26 years, and I have been involved in both clinical research but also in patient care and treatment. Yeah. Certainly, factors are important. First, an early diagnosis is needed because then you can take the appropriate diagnostic and also therapeutic means. So early diagnostic means to identify the disease because there are other differential diagnoses as well. And then once you are sure, or once the physician is sure, this is Stevens-Johnson syndrome, or TEN, toxic epidermal necrolysis, which is a continuum of disease, like one entity of different severity, by histopathology and clinical picture. Then one has to consider the potential causes of the disease. Drugs is one cause. Actually, altogether, probably, let's say 70-75% of the cases are caused by drugs, but the rest is not. So at least 1/4 of the cases are caused by other issues, maybe by viruses, by infections, some we don't know, and this percentage may be even higher in children. So we have to look for what could be the cause. And if you consider a drug cause, then you need to identify the potentially causative drug and stop it early on, because that may help for a better prognosis. Well, once the reaction started, it's actually not so easy to stop it. We know that early withdrawal of the potentially causative drug has a better prognosis. When it's out of the body, then it's better for the patient. But the process of skin death, so that your skin cells die and the skin peels off, that has already started. And it takes 2.5 weeks at least for the skin to recover. That's the minimum time if you have a blister for this blister to heal. But the problem are the complications that some patients run into because they need intensive care, because they were involved so severely. That is one of the problems. And to date, there's no therapy that can stop this process right away. So that is one of the difficulties. On the other hand, of course, we would like to avoid the reactions by identifying the causative agents and perhaps find certain susceptibility of patients. Not every patient may react to a certain drug with SJS or TEN. So is there a way to identify those who have a higher risk? That is the other way of research that we try to follow. I have to say the immunomodulating treatment is still discussed controversially among experts. But I have also to say that some believe in corticosteroids, others believe in intravenous immunoglobulins, but there's not really good data for these substances to help in SJS-TEN. The best data we have at the moment are for cyclosporine A. This drug has been used in other ways in medicine for many years, and we always thought that it takes longer for cyclosporine to have an action in the body. But actually, we could see that in SJS and TEN, rather low doses for a couple of days seems to have a benefit for the patient. There have been 2 larger studies, one in Spain, but the most recent one in France. And the death rate was much lower than one had considered and calculated based on a certain score system. And so we think that this is a good option. The mechanism on how it really works is not absolutely clear. Maybe it has an effect on a cytokine or cytolytic protein called granulysin, which is expressed in the blister fluid of the patients that are developing these blisters in SJS/TN. And the more severe the reaction, we know, the more granulysin is produced, and maybe cyclosporine has an early effect on that, but it has to be demonstrated and proven. For now, this is a hypothesis. Yes, it seems so, but it's difficult as well, because our colleagues from Taiwan who are working with us in this international project called REDISCAR, they identified a certain HLA allele on chromosome 6. And especially they found HLA B1502 in patients who developed Stevens-Johnson syndrome and toxic epidermal necrolysis after a certain drug called carbamazepine. Now, when we wanted to look for this in European patients, we couldn't find it. So obviously there's also an important ethnic issue in that. So people in either China, at least the southern part, and Southeast Asia, they seem to have this allele related to carbamazepine inducing SJS/TEN. But Japanese patients do not have that. And patients in Korea and northern China don't have it. So genetically, there is a difference. However, there's also other HLA alleles that you find in patients of European descent and in those of Southeast Asian descent. And this is, for example, HLA B5801, which is positive in patients who develop SJS or TEN after the use of allopurinol. However, this rate or the percentage among SJS/TN patients after allopurinol is much higher in Chinese and Southeast Asians. About 100% our colleagues could find, but only 55 in Europeans. So it's a bit complicated, and many other ethnic groups have not really been investigated. But we can at least say that patients with Southeast Asian descent should have an HLA test for B1502 before they get a prescription of carbamazepine. Well, besides carbamazepine, there's other drugs in that field too, anti-epileptic drugs or anticonvulsants, as you say, that have a high risk for SJS and TN. Lamotrigine is one. Another one is phenytoin or phenobarbital. And these anti-epileptic drugs have a higher risk. We do not know why, really. What we could observe and what we have seen in our studies is that the patient usually takes this drug for the first time, not the first tablet, but let's say the first continuous use, the first course of treatment, and tolerates it for about 2-3 weeks, and all of a sudden the symptoms appear. So it's not a classical sensitization that happens in the patient, like if you have contact with poison ivy, first time nothing happens, next time you have a reaction. Here it's different. First, continuous exposure that leads to the reaction. We think that most likely, this is hypothesis again, the HLA type connects with a T-cell receptor, and the T-cells are cytotoxic T cells that lead to the skin cells, the keratinocytes, and then the blisters and erosions occur. And the hypothesis is that certain drugs bind to the HLA and are presented to the T-cell receptor. But how this actually works in detail is still not well understood. Yeah, as I mentioned before, granulysin, for example, is a biomarker. The expression in the blister fluid tells us how severe the reaction is. But, well, you see this anyhow when you see the patient, but it's good correlation. And it has shown us that this cytokine is much more important than others and this should be the target for therapy. There's other cytokines in the blister fluid as well that are elevated, like FAS and FAS ligand or TNF-alpha, but not to the same extent as granulysin. So this is under investigation in terms of specific treatment directed to work against the high expression of granulysin. Okay. Other people have also looked at granulysin levels in the blood, in the peripheral blood. It has not been so well established yet, but this is also an idea of having a marker on severity. This is what I know at the moment, what people are working on, but there will certainly be other considerations as well. But for the moment, we do not have a certain marker telling us this is SJS or this is another disease. Our colleagues from Taiwan and Japan are currently preparing a clinical trial using corticosteroids as a pulse therapy. They're working on the protocol, and they have presented in our international study group, and we have discussed it and made some suggestions. So I hope this is something that's going on in the future to help clarifying the question about glucocorticosteroids, whether they are really helpful or not. Our colleagues in France are continuing a study on cyclosporine because they wanted to have a better dosing system. And so far in their studies, patients that were older than 16 years were included. But also, I think the highest age of a patient was 66 or 67. So we do not have good data on very young and very old patients, and this is something that we are discussing and planning on. But I have to say, clinical trials are not easy to do, because usually, at least in many healthcare systems, patients are in different hospitals and different units, and they come all of a sudden, and from one day to the other, you have to make the diagnosis, you have to decide on the treatment. If you want to do a good randomized trial, you have to have the protocol in place. It's quite a challenge to do that. Well, I have to say, in the early years when I was working in this field, my colleagues and I thought, okay, people who survive, they shouldn't have too many problems. You probably know that the death rate in these diseases is quite high. And it's related to the severity of the disease as well as to the age of the patient and the underlying conditions. Now, we have done some follow-up studies after 2 months, 1 year, and 5 years now. And the 5-year study is just, has been presented at a meeting and will soon be published. The percentage of survivors still having problems is very high. And one of the major issues in these patients is dry eyes and all complications related to ocular involvement. So the most important thing that we are trying to teach the treating physicians is get an ophthalmologist involved early on. Ophthalmology care is needed every day, very constantly, even if in the beginning it doesn't look so bad with the eyes. And then these patients need follow-up. And we have established here in our city a close connection and collaboration with ophthalmologists, and I think this is needed in many places. So I think a focus on the eyes, and patients need to be trained how they can do certain eye care by themselves, and they need help financially, but also in terms of medical care. And I think one problem also is that many physicians do not know how to address patients with that disease. So if you come to your doctor or to any doctor saying, I had Stevens-Johnson syndrome, everyone is panicking. So I think it's good if there's organizations like yours who can help patients, who can tell them where the specialists are and teach them in many ways. Well, I think what is really important that the families and the patients have a good contact for follow-up, and when new things occur, that they have someone to address. I think that also the families and the patient associations have the power to encourage research, because I unfortunately have to say that research in this field is very difficult because it's a rare disease. Many people providing research money don't think it is necessary to do the research. And so I think that the patients and their families have a lot of power to encourage this and ask for it.